those of you who were here with us last year, there was so much energy in the room that afterwards people wanted to find a way to continue the dialogues, continue the process, and try to tackle some problems that were raised during the first summit. And so afterwards we put together 3 work groups that we called Principles, Technology Solutions, and Consumer Education. And where are our consumer education people? Kathryn? Where did Kathryn go? I saw her in here. Well, Kathryn and David. Okay, so these groups attempted to come together, and they were focused mainly on the problems that we felt emerged from last year. One of them was, of course, do we need some kind of new sets of principles for privacy? And so Jim will present that at the end. Michelle's not able to be here today. It was also very clear, particularly in regard to everything that's happening in the states now, the push to exchange information and health information exchanges, the rapid deployment of EHRs at the state level. We really felt that there needed to be a group that was interested in figuring out how to assist consumers in states that are setting up all of these systems. There were what would be the best way to get information to people in the states. And so Kathryn Serkes and David Wanser agreed to chair that group, and it's about outreach and consumer education. And then the last work group was the idea of trying to identify technical solutions. And they first thought about the idea of taking off the table problems that are actually mythical. You know, there are problems that have been solved that certain parts of the industry say are not and claim can't be, or they're too difficult. And so I think originally the technical solutions group idea was they would identify and take off the table the problems that were solved, and then they would identify problems that had technical solutions where there were some things being developed but they weren't implemented, and then they would be left with a list of, well, what are the core really difficult problems that need to be solved? So those were kind of the premises that the work groups started out with. And so I think we'll let Tien from the Electronic Frontier Foundation talk a little bit about what happened with the Technical Solutions work group, and I think they have some slides. Right, Kat? Thank you.
Hi, so my name's Tien. I'm a senior staff attorney with the EFF. One of the areas that I work on in privacy is electronic health records privacy. I don't do much on the national scene, though. Most of my focus has been in California, which allows me to sort of see up close and personal sort of the fractured state of understanding of health IT. My co-chair, Andrew, is sick or something, so he wasn't able to come down for it. So, and he is a technology guy par excellence, so I will stumble through this, basically not talking directly about the technology. Deb did a good job of really framing what the purpose of the work group is. I found over years of conversation in California that time and time again we were being told that we can't do this as a matter of policy because the technology doesn't exist. And then time and time again we would find that, well, in fact, the technology did exist in some form here, there, or elsewhere, but either the folks in the room didn't know about it or didn't want to admit it. And either way, that leads to policy that is unnecessarily weak from a privacy perspective. And even at the very, very simple edges of the privacy spectrum, questions about consent and questions about data segmentation, we found this to be problematic. The other aspect of this, of course, is not just the policymakers themselves, but the vendors, right? And you know, if Long Beach is going to do something, if San Bernardino County is going to do something, they're going to do it because it's commercially available. And if they're not going to invent their own solutions. We can talk a lot about how they could do it right, but if it's not commercially available, they're not going to do it. So, and here we have, again, issues about whose incentives are really operating. If you're a large vendor, obviously you're going to try to serve the big market. Maybe there's a small market for folks doing part 2, alcohol and drug abuse, behavioral health, but those are not necessarily the big vendors. And so, once again, you have this gap between what is possible and what is actually available. So our goal really is to try to bridge that gap. It has been a year, and we haven't actually gotten off the ground because one of the problems is that at the end of the day, it's kind of hard work to figure out these technical problems without funding, without research. So I think one of the takeaways from our previous year of discussion about this is that we do need to either figure out how to crowdsource these problems better, bring in the expertise that's available on a volunteer basis, and then add to it, augment it with some actual money. But then we also have to figure out what is the goal we want to really have. So I think that this was our idea about what kinds of problems were out there. And we're going to be doing a more detailed session tomorrow. Each of the work groups is with people who are interested in helping out. And I think what I want to do with this slide presentation is for those of us who are interested in talking about how to proceed on technical solutions to go over more thoroughly the examples that we pulled together of things that are partial solutions or complete solutions that need to be disseminated. But one of the other things we have to figure out is who's the audience for this really. Is it just policymakers? Is there a way to go to the vendors? Or are we going to actually need to build some code? And I'm going to pick and choose between a few of the remaining slides to give my other panelists a chance to talk. But I'm going to pick on a few problems that I think are particularly important in this area. I think this one is actually a really, really big problem. Because you can have the technology to encrypt, you can have the technology to segment, you can have a lot of technologies for built into the code for doing things, but you still have to agree on what these things actually mean. And you also have to figure out how to make it work within the context of the actual provider and treatment environment. If our issue is segmentation, and it is a question of, say, making sure that certain kinds of prescriptions are segregated out, because those are going to create very strong inferences about something that we don't want to get out, versus other kinds of medications that, well, only if you have 7 other meds and 7 other facts would someone actually be able to decide, yeah, this person has this kind of a problem. Then you're going to have a different issue. And that's going to require, at some level, clinicians understanding how to tag things, how to flag things, so then that the software can operate on it. But this, I think the semantic representation issue is a very serious one. This is a more common sort of standard problem, security. I mean, we touched on this just in the last panel, right? And I think the important thing to remember here is that the security problem isn't a health privacy or a medical security problem. We have on the Hill today an enormous discussion about cybersecurity in general, and we see the general problem with all mobile devices, mobile apps, and platforms. A tremendous amount of data leakage. It is not specific to health privacy. Medical apps and medical information simply end up in there as something that creates a more understandable problem. People get that there are medical facts they do not want to have revealed, whereas they might think, well, whether I like pizza or not is not that important. People have a very, very different attitude towards their medical history. But one of the things that's a problem is that we do not have adequate incentives for security in the general sort of computing environment. We have lived for many years with extremely vulnerable operating systems in very, very common, widely used platforms that contribute to all sorts of cybersecurity problems. And the question of how do you give the vendors incentives is a difficult one. So in the full presentation, I think is there a way to make the slides available sort of on the website?
Yes, of course we can do that. No
Okay.
problem, yes.
Yeah, the rest of this presentation goes into some of the things that we have looked at that we consider to be candidates for saying that these are solved problems. Progress in the area. ONC has, in fact, been doing stuff within its standards and implementation framework that we think is very positive. But, you know, here again, when we looked at this a few weeks ago, it's like, well, we didn't know about this. I don't know who else knows about this. I'm quite sure that Cal Ojai, who I work with in California, doesn't know anything about it. And we have a real dissemination of information gap. So what I think I would propose, and this is something I'd love to talk about with people tomorrow more about, is how do we go about creating a way to actually get this information to the policymakers, particularly in the states? Because I think that they're really the only, or this is my own view, that they're the only ones who have the ability, other than the federal government, I don't think the federal government is going to touch it, to really give the vendors the correct incentives to actually require the right level of privacy and security and to adopt the known technical solution. So if people, you know, have a chance to look over the slides, or we'll go over that tomorrow, then we can talk about how we might move forward on it. We are prepared at EFF, for instance, to set up a website sort of in coordination with PPR that will be available as a way to at least make public the sorts of things that we want people to be able to do. But, you know, that's just a first step of sort of making it available. Then we'll have to drive people into actually thinking about it and picking it up within their state HIE and EHR processes. So I'll stop there. Thanks very much.
Thank you. And I know Lee and Andrew, even though he's not here, would welcome all of you that are technical experts, but also policy experts too, because, you know, of course, a lot of the problems come up when the technology is developed without a real knowledge of law and policy. So thank you, Lee. I guess we'll turn now to Kathryn Serkes and Dave Wanser. They were... yeah, do you have a slide presentation?
Jim's going. Have you?
No,
Would you like?
I'm going last.
Either way.
Okay.
Did you? Whatever you want to do.
You want me to go?
Go ahead.
Well, all right.
Okay, all right. We're changing the order. That's fine.
All right.
Whatever.
Yeah, could I do it up there? Because I can't. I'm an old person. I can't see.
Oh, absolutely. Yeah. No.
I want to hear what I'm just anxious to hear what he has to say.
There you go. Okay. Well, actually, since your work group is the disseminating work group, trying to think about how to get the information to consumers, it makes sense for
That's
you to
right.
hear from the principals work group and the technical work group first. So,
Okay. Well, what do you think, Kat? Can we get it up there? There we go. All right. As Deborah said, one of the things we decided to do, or their group decided to do last year, was to maybe think about coming up with a set of basic privacy principles. As I mentioned earlier, every medical profession has their standards of professional ethics, but professional ethics don't apply to non-professionals. So, and since more and more healthcare is winding up in the hands of non-professionals, the idea was, well, could we put together a set of principles that would be somewhat based on standards for the ethical practice of medicine and psychiatry. And as you heard Joy Pritz say earlier, and she's absolutely right, you can't have a regulation for everything. But it is also important to understand that under HIPAA, if as a practitioner or a covered entity, you decide that you want higher privacy protections that you offer to your customers than HIPAA requires, then you will be legally liable for that. HIPAA says right in the regulations that if you adopt more strict privacy standards, then you can be penalized for that, and you can also, of course, you can also be sued for that on that higher standard. So no lawyer that I know in this country is going to tell his healthcare clients to do one jot more than what HIPAA requires, and as we all know, that's the floor. So the idea behind the privacy principles was, well, maybe if we could set a more general requirement, then businesses would aspire to it, and patients would feel like their privacy was better protected. I had the privilege of working on the American National Standards study that came out on March the 5th of this year, and there are copies of this out front. And if you look, this was a real illuminating experience for me because I worked on it for about a year with them. And what we found, could you roll the next slide there, Kat? Oh, I got the clicker. All right, maybe I can do it. I have no idea. Oh, great. Okay, I got to do it all myself. All right. So this is the title of the report that came out in March. And it was fascinating because what we found, and hundreds of organizations worked on this, and much bigger organizations than just our little firm. But what we concluded was the country is in the middle of a health privacy crisis. I mean, we've got millions of records, health records, that are being disclosed improperly, and that's just the reported breaches. But we also found, let's see if I can get the, oh, here we go. Oops. Is that going to roll? No, doesn't work.
So it's not left and right.
Oh, sorry. I see why I went into law. Okay. What we found is that that HIPAA and electronic health records really are a game changer from a business and legal standpoint. For the first time, and this is not an overstatement, I looked at this when we first wrote it and I thought, is this really right? But it is really true. And for the first time in the history of medicine, health information technology makes it possible to improperly disclose millions of records in a matter of seconds. The VA breach that we all heard about in 2005, 20 million health records disclosed. Think of the paper load that would be. Those people would not be hard to find that were stole it because they would be driving a whole bunch of tractor trailers. But it was instantly stolen from a VA employee's basement. So we see this almost on a daily basis. We see these are breaches. Paper breaches always used to involve just a few people, but electronic breaches involve thousands or millions of people. We also found that it's possible to steal this information without having physical access to it. Somebody alluded to that earlier on one of the earlier panels. You used to have to go into the clinic to steal the information. You have to have some ruse for getting in there. Now you can be in Belarus or anywhere in the world. And when you steal it, you can sell it and post it in an infinite number of places. A paper record can only appear in a finite number of places. So, and the third difference that health information technology made is that breaches can now occur in a way that you can never restore someone's health privacy. You cannot get an electronic impulse back. Okay, so that's bad, but what does it mean from a law standpoint? It means that the legal liability could be higher than we have ever seen for paper records. Now, the courts, so far, have been reluctant to find damages unless they could be proven. I don't think that's going to continue. We saw a recent breach where I think there were 8 class action lawsuits filed immediately with a unnamed federal agency, I believe, lost records. And all of those class actions immediately related specific damages that were occurring to those individuals. You know, lost medical identity, claims filed on their insurance, Medicare or healthcare fraud, all sorts of healthcare fraud. So we're looking at liability we've never seen before. And this, I can tell you, I was involved in the development of the HIPAA statute and the implementing regulations, and nobody was talking about this. This is an unanticipated cost. Look at the casualties here. Now, these are just reported breaches. These are just the breaches from 2005 to 2008 are just those that were picked up by the newspaper. And remember, but prior to the breach notice rule, there was a huge incentive to not tell anybody when you had a breach. But these are just the breaches we know about from the newspaper headlines. Nearly 40 million people had or nearly 40 million electronic records were breached between 2005 and 2008. In the 2 years since breach notice has been required under HIPAA, we've had 18 million Americans with reported electronic health privacy breaches. That's the population of Florida, according to the New York Times. Now, if this were a flu epidemic, the epidemiologist who was here probably would attest to this. If this were a flu epidemic or an infectious disease, this would be called an epidemic. Okay? And we would be mobilizing, the CDC would be mobilizing every resource to stop it. So we got a problem here, folks, as they used to say. Houston, we have a problem. We also see in the study, we did a survey as part of that study that 96% of healthcare professionals had at least one privacy breach in the last 24 months. That was the average number of records that are breached in an electronic privacy breach. I mean, we're not talking paper records here anymore, folks. The data breaches are occurring in healthcare 3 times faster than banking and finance. I heard someone say, oh, look, nobody steals credit cards anymore. Well, that's because they're all stealing healthcare information. And most providers that were surveyed said they believe that electronic privacy violations will get a whole lot worse before they get better. We only got less than half the hospitals in this country on electronic information systems already, and less than half the doctors. Once we wire the whole nation by 2014, according to the administration, the fellow from OIG is going to be really busy. So what we found was, as a result of the privacy violations, 60% of the public, or most of the people in the public, don't believe the laws are protecting their privacy, and over 80% of the regulated industry don't know what they're supposed to do. The laws, believe me, I help my clients, my healthcare provider clients, every day try to comply with the privacy and security law. Holy smoke. Our law firm, I mean, talk about injustice. Our law firm had to comply with the security rule because we're a business associate. And that hit home, I can tell you. And it was hard, really hard, and I'm still not sure we got it right. So I don't know how any healthcare provider in this country today knows whether they're in violation of that regulation or not. We noticed that the administration in February issued a Consumer Privacy Bill of Rights as part of the Consumer Data Privacy in the Network World. And the introduction to that says, the privacy protections are critical to maintaining consumer trust in network technologies. Neither consumers or customers have a clear set of ground rules. The problem is they exempted health care from the consumer privacy principles. This is more, so now we have a situation where non-health, less sensitive non-health information is entitled to greater privacy protections than health information. We thought that was odd. So we thought, okay, what we'll do is we will just model our health information privacy principles, not just on standards of professional ethics and law, but we'll model them on the Consumer Privacy Bill of Rights issued by the White House. So that's what we've done. You'll see you have a copy of this in your packages, in your bags. This is the letter from this is an excerpt from the letter that is a cover letter to this document issued by the White House, the Consumer Data Privacy Bill of Rights. And it says, I mean, privacy is not an out-of-date concept, according to the President of the United States, who, by the way, signed that letter. It's been at the heart of our democracy from its inception, and we need it now more than ever. Subscribes to Justice Brandeis's statement that privacy is essentially the right to be let alone, and that this administration, as a policy, as a government-wide policy, starting now, will implement that Bill of Rights for non-health information. So again, it struck us as logical that maybe then what we need is a Consumer Health Privacy Bill of Rights. And this is all of these concepts. I'm just going to flip through them quickly here because we'll go into them in more detail tomorrow. But these are all based on the principles for non-health information issued by the White House, tweaked somewhat to make them more relevant to healthcare. So there are a lot of things you've heard about this morning from panel members, say, individual control, accountability, transparency, all those great things. By the way, none of that appears, other than accountability, none of those things appear in the current HIPAA privacy rule and security rule. So individual control, that's what it means under this proposed set of privacy principles. Transparency, people have a right to understand where their information is going, how it's being used. Respect for context, as Justice Sotomayor said in U.S. versus Jones, simply because you give consent for disclosure of information for one reason doesn't mean it should be disclosed for every other reason. I think she's absolutely right about that. Security, we already have security requirements, but we put that in the principles as well. Access and accuracy, have a right to full, complete access of all your personal information, should be able to correct it, focus collection, reasonable limits on it. Again, now, by the way, all these principles were not taken out of thin air. These principles were taken, as I said, from the Consumer Data Privacy Bill of Rights, which in turn took the principles from the European Union privacy regulation that all European countries are signing on to now. Just to let you know why the administration issued the Consumer Data Privacy Bill of Rights, there is a provision in the European Union regulation that says all member countries must sign on, and if you deal with any country that doesn't have privacy protections that are at least as strong, you cannot deal with them. You cannot carry on commerce. So that's why you got to follow the money. So we had to come into compliance with what Europe was doing in order for companies in this country to continue to do business in Europe. Of course, that was before all the banks failed in Europe. Accountability is another one that is key. One of the requirements. Applicability. This is an important one because as the first head of the Office of the National Coordinator said, not while he was there, but after he retired, HIPAA is completely out of date. It was designed only for filing insurance claims, and it only applies to covered entities and their business associates. It doesn't apply to all of the hundreds and hundreds of organizations of people who now handle electronic health information. So this says these privacy principles apply to anyone who handles the information. Enforcement, the Consumer Data Privacy Bill of Rights from the White House says you got to have enforcement or it's meaningless. So we put an enforcement requirement in. Notice, you should be notified. You know, the one thing as a consumer I want to know, I only want to know one thing, and you can forget 1,500 pages of HIPAA regs. Do I have a right to health information privacy? That's all I want to know. If my doctor tells me that or my technology firm tells me that, then I'm going to feel pretty good about it. And if they breach that, my expectation of privacy, I'm going to sue them. So that's fine. That's fine by me. But I do need to have notice. So that's it. We'll have more on that tomorrow. We'll have more discussion of it. But by the way, I want to thank Michelle DeMooy for helping to work on this. And I want to thank also the members of the Privacy Principles Work Group for their input. And if anyone, by the way, I wanted to say, this is the first time these privacy principles are being rolled out. And we also recommend in those privacy principles, as you see, that they be adopted in federal legislation. So you're likely to be seeing these or something very much like them on the Hill. So you are the first people, members of the public, to see them. Thank you.
Thank you, Jim. That was fast and powerful wake-up. Kathryn and Dave?
Clicker.
Sorry.
Clicker.
Okay. We would have gotten a lot more done, but we had to wait for Jim's group to get done. So I'm going to, that's our excuse.
See ya.
At the end of last year's summit, we were kind of given this charge and essentially help consumers understand the issues associated with control of their protected health information. we kind of took consumer broadly because ultimately consumers' understanding and the actual implementation impacts how policymakers do their work and what providers do in making sure that those kinds of things are transparent and available to consumers. So we looked at that. The work group members here, we've had more or less at different times, but we've had a very diverse and interesting group of people with a lot of different valuable insights into how we should go forward. Our focus since the last summit, Kathryn, do you want to talk about that, or do you want me to do that? This is completely unrehearsed between the two of us.
Okay. I'll go ahead with this. Well, as Dave just pointed out, last year, one of the takeaways from the summit last year was to begin to identify some of the impediments to privacy, to medical privacy. And so this year, when we talked about planning the summit in general, that we wanted a very strong focus on solutions, so that we all start to move forward. So as all of the sessions, in addition to the work of the work groups, to be focused on moving forwards and solutions. So with that, our charge being to figure out ways to get the message to the public. The first thing that we needed to do, I'll just walk you through our thinking so you can understand where we're coming through, because I'm looking around the room and I'm going to stare down some particular people and psychically make you come to the work group meeting tomorrow. So I'm recruiting here as I speak. To make it sound like a thrilling opportunity for you that you cannot pass up, because this is your chance to make a difference. So keep that in mind as I speak. But so you can go through our thought process, which is that we're looking at first of all, we have to go through basic communications analysis, which is who is our target audience and what is the message. Then once you define that, you have to figure out how do you do that? How do you reach them? What tactics and specific channels do you use to do that? And you would do that with any problem. So as we look at who is the target, we actually had some surprises, because when we started out, we started thinking that we were mostly doing consumer education, that we were trying to get this message about privacy to the public, because as Jim points out, you see all those breaches that he pointed out, and the problem is the public is largely unaware of the breaches, including people whose records have been breached. That's one of the problems in getting people in here to talk about it, is proving these negatives. So we know that we need to go to the public, and that's where we thought our focus was going to be. But as we got more input from our wonderful working group, we started realizing that we had other target audiences, and that included medical professionals and regulators, because the medical professionals aren't exactly sure and what to communicate to the patients, and we're also finding, shall we say, some disturbing gaps in knowledge with the regulators and politicians, who are actually the ones who are putting together the laws. I'll give you a very brief example, and that is I sit on a task force of state legislators, and we were listening to a vendor speak about a system, and the question from the state legislator was, well, is this HIPAA compliant? And the vendor said, yes, of course it's HIPAA compliant. And the legislator said, oh, okay, fine. And I said, well, wait a minute, do you understand what that means? And quite frankly, the legislator had no idea what that meant. She did not know what was in HIPAA. She doesn't know how that impacts patients. All she knows is that she's supposed to ask this phrase, is it HIPAA compliant? So we need to make sure she understands what the elements of privacy are, and because she's the one writing the state laws, and as we're looking at state exchanges, that's extremely important. And the same thing with the providers. Now, the providers are mostly getting their information from their third-party contracts. This is a group piece that was put together by a consortium. They did a version for the public and a version for providers. And I've read through it, and I'm not exactly the village idiot when it comes to this stuff. I can't code it, and I'm not a technical person, but I've been working on this privacy policy for quite a while. And this wouldn't help me if I were trying to convey this to an audience. I would read this and not know what to tell my patients. So we decided we needed, that would be our audience, that we're looking at regulators, regulators, providers, and the public, and even insurers and plans, because they are the ones who at this point are largely responsible for putting out the materials that people are seeing. And also when we look at the regulators, we would add to that, for example, HHS, because as Jim's pointed out, there will be some public education now from HHS. There's money allocated to do so. Let's make sure that we can have some meaningful influence on that process. Now, so those are the audiences. Then the question is, what's the message? Well, we have a general message, which is that we know that people have concerns over privacy. But we started to figure out that if you ask, there's lots of polling there's a number of polls that have been done that people are concerned about privacy. But that doesn't tell us much, because what does that mean in reality to the public? How far does their concern go? What are they willing to give up? What are the trade-offs? Where is that tipping point for them that they're willing to trade off some privacy in exchange for convenience or better data or whatever? The real question that we think needs to be answered, and let me see if you all agree with this, we want to know what the public doesn't know. And we're kind of back to this issue of what Jim just talked about, which is, do they understand about consent now? Do they even understand what a breach is? What does that really mean? Do they know that they have, what do they think they're signing when they sign the HIPAA form? Do they know that they can ask for their information to be used in certain ways? So that's where we think we need to go with some polling to help define the message. And then finally, the next step then will be we've identified the audiences, we need to do the polling, which is a step that needs to be done. And we've been assessing these approaches, and then we want to look at the current information that's out there, the current public information tools that are out there. And Dave's going to step in and talk about, we're working on developing criteria. And how to move forward with that. So what we'd like to do is, as HHS ramps up and these principles are coming generated from the summit, then what we can do is figure out ways to, shall we say, influence insurance companies, plans, vendors, et cetera, as well as legislators and regulators, to use our recommendations for what makes a good public education piece as their standard, so that they have some guidelines. We're not relying on them to create the guidelines for what makes a piece that actually will educate people in a useful, plain English manner. Like if you read some of your HIPAA advisories. I wrote a HIPAA advisory back when it first went into effect, and mine was 1 page, and I think it did the job. But now we're seeing very, very long things that nobody reads and are not meaningful to people. So we need to get to the point. If we have the recommendations, and it's been my experience that if you go ahead and do some of the work for government agencies, that they are grateful if anybody's here, because they're so strapped that if there's information available and they can borrow it, then that they will. So we'd like to create a product that they are welcome to borrow. And then moving forward with our next steps then will be, how do we get that out to the public? So I'll come back in. I want to let Dave talk for a minute about what we need to look at in that criteria, because that's part of what we're going to be working on tomorrow.
Yeah, and part of the challenge is, how do you make this issue resonate with folks? And let me ask this question. How many people here are concerned about privacy protection? Okay. That's pretty much an easy one, and it doesn't really get you when I ask you that question.
And world peace, too.
How many of you here are on LinkedIn?
Oh,
Guess
yeah.
what? Your password got stolen.
From Uzbekistan or somewhere today,
Yeah,
right?
Your password got stolen. I'm not kidding. So that resonates at a slightly different level, because when you hear that, you go, oh, I wonder what that would mean to me. And that's kind of our challenge with looking at the criteria. So what we did was kind of use the topical areas that are under the Consumer Privacy Bill of Rights, but under that we kind of surveyed other criteria. And so did a mashup of the kinds of things that are covered, and I'm just going to fly through this, but it'll be available otherwise. But if you take everything that's relevant under these topical areas like individual control, then what are some of those issues? And so we did that with individual control. We did it with transparency. And I'm not going to read through this for the sake of time. We did it for respect for context, so that you can look at the kinds of things that would be covered there. We did it for security and access and accuracy, kinds of things that might be covered there. Focused collection. So these are all the things that Jim covered, and as that became clear as where their group was going, we just said, well, let's take all the content that's relevant, because that's going to be kind of our blueprint from whence we look to the other efforts in polling and other aspects of education. Accountability, and that's about it. So that's what we've got. And Kathryn, back to you.
Okay, we'll go forward. Okay, so here's where we're moving forward now. And that is that we need to develop the polling questions. And this is key, because exactly what Dave said is we need intriguing polling questions, not do you support privacy. We need intriguing polling questions that will get people's attention. For example, a few years ago in a survey of a poll of doctors, I asked if patients had ever asked them to lie on their medical record to protect their privacy. And that kind of question, to have a number that 2 out of 3 doctors has been asked by a patient to lie on their medical record. That's the type of thing that has more impact. So we need to develop those questions, and given that we don't have budgets or funders yet to do anything like focus groups, which we'd love to do, we need to use our collective wisdom from this summit and this room and across the country to develop the poll. We also need help in putting together a proposal to and opportunities to either A, get some questions into other surveys, or to get some funding for us to do the survey, the polling. I think that this will be one of the best tools that we have to draw some attention in a meaningful way to the issue, and in a way that is very understandable to people. We are looking at, as I said, identifying the current tools and analyzing them, and moving forward with that to develop our guidelines.
And I might mention, one of the things we did was we gathered up some existing patient education information around privacy. Something that was used by one of the health information exchanges, something that's part of a health system's consent authorization, things like that, and we just kind of ran them through these criteria. And I think if we can, as a part of kind of following up on the polling and the results and how people have prioritized these issues, start to be able to give folks a checklist that they can use against these different privacy notifications that are used by health centers or health information exchanges or individual practitioners. So it's ultimately bringing it back around, and how, this is a set of things that consumers can remember. We've talked about having something that is no more than the fingers on one hand, so that you can actually go in and kind of click through that as you're looking at these materials in offices, and then hopefully create some materials that get at this issue of informed consent.
Okay. And then finally, what we need to do is a glossary of terms. We need a repository for, again, plain English understanding. I will guarantee you that most people don't have a clue the difference between an EHR and a PHR. And again, I had to do this in my presentation to the state legislators. They did not know the difference. They didn't know what NHIN is. They didn't know. And not only did they not just recognize the alphabet soup, but I had to still explain to them the difference between a PHR and an EHR. So these sound like such fundamental issues, but they are so crucial to building our public support. We've also talked about kind of putting together, as Dave, I think what Dave is kind of talking around there is almost a HIPAA 101 for an understanding of people in a very, very simple way, in addition to these guidelines for what should be included in the educational tools. Then when we get into actually tactics, the things that we're talking about are releasing the poll. We need a speakers bureau of people who are willing to speak, do talk radio, go out and talk about it, write op-eds, etc. And that's where it actually gets fun. And we would like to hold a congressional briefing because, as Jim Pyles mentioned, that the target here is to get these principles into federal legislation. So we're going to start building a month with this summit as the starting point and this coalition. We're using that to kick off a legislative agenda of moving those principles forward and into law. So that's as we're going forward. And I wanted to show you I just wanted to show you something. That I have a new survey of physicians coming out that will be actually officially released here tomorrow. But here is this is a brand new number from doctors. And our number on this was 699 respondents. We had a pretty statistically significant number of responses. How do EMRs impact medical privacy and confidentiality? 67% say that they compromise. So it's having data like this that we can use to back up our positions and everything, I think will be very worthwhile to you. So you can go ahead and use this one as of tomorrow and start to talk about that if that helps you in any way. So moving forward, we're looking for people to help us on this, and even if you can't be at the meeting tomorrow, please come and get my card or get Kat or Adelie or Deb and tell them that you are available to the group, and then we'll be sending out subsequent emails for people who are willing to speak and do some things even if you can't be available for the work group. Thank you.
Thanks.
Early? Okay, thank you. Okay, I'm going to stare down everyone just like Kathryn did and try to convince you that you want to be involved with this.
Should we just do it right here in front of everybody and nominate them from the floor?
There you go. Okay. Seriously, thank you. Welcome, Christina. Okay, well, I guess if that's the case, then we can get to our sort of Academy Award kind of moments here with the best privacy technologies of 2012, and so we'll let you all. Oh, questions. Oh, I'm sorry. Questions for the work group chairs.
Earlier.
No? I thought you were pretty definitive. Maybe everyone agrees.
One actually thing I would add is on the education piece. There is, when you say education, it means different things to different people. And I've looked at the instructions coming out from ONC and the Office of the National Coordinator. And they do require, and they are conducting education of the public, but it is education on the benefits of an electronic health record.
Thank you. Yes, thank you.
So it seems to me with something on the order of 60 million electronic records breached, that part of that education should be the potential for having your health privacy violated by electronic health records. Also, particularly since HHS has concluded back in 2003 in the security rule that no electronic health information system can be made absolutely secure. Now, of course, paper records can't be made secure either, but the consequences of an electronic breach go far beyond anything we've seen with paper records. So if this were a medical device, it could not be approved for use on human subjects without full testing. And there has been some suggestion that perhaps it should be classified as a medical device and go through FTC clearing. But anyway, that's just part of the educational process.
You know, and I'll just add a quick note to that. I just wrote a piece this week, and I titled it, "What's the Big Deal with Medical Privacy?" Because, quite frankly, that's the question I hear all the time. I hear it up here on the Hill from congressional staffers and other people. What's the big deal with privacy? What's the big deal with medical privacy? There aren't that many people breached, and people want to share their records. It makes it easier. So we're starting from a point of people saying, "What's the big deal?" And so to even explain that there is a big deal, people are not just overjoyed at the prospect, and why.
Yeah, and I would say, too, I want to make sure everybody understands, I am not a privacy advocate, but I am an advocate of quality health care, and I am an advocate for the principles of the Constitution.
Yeah.
And it seems to me there's electronic health information technology and records. It's just a tool. It's like an MRI. There's no reason to change medical ethics because we have health IT. I mean, it's just it's a good tool. I mean, and it may one day, it won't save, my prediction, it will not save 100,000 American lives, and it will not save $77 billion a year, which were the two arguments for it when the High-Tech Act was passed. But it will help better coordinate care, probably one day, if they get it implemented properly. It probably will allow reimbursement methodologies that we haven't seen before, such as saving sharing, because you've got to be able to know what the claim would have been if intervention hadn't occurred, and then calculate what the cost actually is. Those are good things. But there's no reason to abandon fundamental constitutional rights and medical ethics in favor of the use of a tool.
And I want to plug the Technical Solutions panel because I think that education is a hard thing to do. And even if you educate folks as to, oh, there is a problem, because that's a lot of what you're talking about, not just the first, there is a problem, and then here are the principles that should guide the solution. But none of that actually gets you anywhere if it's not actually available within the short term, because what determines how our medical information is going to be treated is actually what is in the box and what's available in the software. And we need to bring that, make sure that we get that as good as it can be to match the values we want to protect.
And if we know we have a electronic health privacy crisis, an epidemic in this country, why are we putting the pedal to the metal on implementing health IT now before we put the privacy provisions in place? I don't understand that as a
There's so
consumer.
much profit to be made.
Oh, good answer.
Money.
As one of my doctor friends says, the answer is money now. What's the question?
Well, they've all made their pitches. They want you to come and be part of their work groups, and so thank you all very much. I want to be in all of them myself. Thank you.